get started.
Okay. Hello, everyone. Welcome to today's SIPC seminar. It's an honor to introduce our speaker, Dr. Brody. Dr. Brody is the Associate Director of the Hartford Institute for Geriatric Nursing and Associate Professor of Nursing and Medicine at NYU Rory Myers College of Nursing. Dr. Brody is also the founder of Aliviato and the pilot core lead of the National Institute on Aging Impact Collaboratory. He is currently the principal investigator of 2 NIH-funded large-scale pragmatic clinical trials to improve the quality of care and quality of life for persons living with dementia and their caregivers in the community. Dr. Brody is also a fantastic mentor and teacher, and I was fortunate enough to have Dr. Brody as the chair of my dissertation committee. So without further delay, I'll turn it over to Dr. Brody.
Thank you, Dr. Morali. And it was Columbia, it is lucky to have you as a valued postdoc on their team. So I'm grateful to be here today with all of you, talk about where we are and where we need to be in creating health equity in palliative and hospice care research and practice. Just to give a little bit of background, I am a geriatric and palliative care nurse practitioner. In addition to my academic role, I do provide consults at NYU on both services, though at the moment I've been doing more hospitalist type stuff because of COVID, so have gotten to see a whole other side of the hospital. Just in terms of the talk, I have no relevant disclosures. Here's the obligatory funding slide. And I thought I would start by asking your permission. In palliative care, we like to ask permission of patients and families as we have tough conversations. And so I'm going to do that here as well. Some of the concepts and constructs we're going to talk about today may make some of you feel a little bit uncomfortable. It may not. I may also not present them always using the best language, but will do my best to do so. So I'd like to ask your permission to participate and to have a thoughtful conversation as we go through this. I'm also going to ask your permission to bear with me because it was really hard to get this down into a reasonable amount of time, because this could honestly be an all-day workshop that we're talking about and then some, to really dig into some of the constructs that we probably need to in this field much more than we do. So I'm going to take virtual nodding as your permission and move forward. And I thought I'd start with the first time I heard anything about inequalities within this field was in 2000 as an undergraduate student at NYU working at the Hartford Institute for Geriatric Nursing. And this was Sean Morrison, looking a little younger back then, dear colleague at Mount Sinai. And he found in a New England Journal of Medicine article that he also presented at our bioethics symposium that in New York City, about a large percentage of pharmacies in largely areas of that are predominant with people of color would not carry opioids. And so there was a significant amount of racism involved in how pharmacies were gatekeeping to not provide adequate access to pain control. And so this was my first introduction to that in the frame of serious illness. I think ironically, there is probably a little bit of positivity that came out of this racism in that we overprescribed opioids. So in some ways, to all populations. So in some ways, maybe we were preventing some level of additional addiction within these areas. But overall, this is a bad thing, right? This is racism that led to this, and pharmacies not wanting to provide effective treatments for pain control for seriously ill individuals. And so, I come from the lens of, thinking about this for the last 20 years in various lights based on this study. And I was planning to have a little bit of a different lead-in from there, but this kind of has come up over the last few weeks. So the American Academy of Hospice and Palliative Medicine presented what must be one of the stupidest counterpoint articles I have ever I've seen in the last 15 years in palliative care, about a patient who had opioid use disorder, substance use disorder, and there was a counterpoint within their quarterly newsletter. This is, the Physician Specialty Society, about whether this patient should get a chemotherapy because they were not adequately treating their substance use disorder. And so this was an aggressive chemotherapy with a 1 to 2 month life expectancy with chemo and maybe a 1 to 2 year life expectancy. And there was actually a counterpoint to providing aggressive for not providing aggressive chemo in someone who will not actively treat their substance use. I can think of many, and then PalliMed, which is one of our two predominant blogs in the field, gave a nice counterpoint that was interdisciplinary about this. But the fact that we are even having this debate in one of our professional organizations' newsletters shows you just how much the field still has to go. So I'm just going to let that sit there for a minute. Our other professional organizations have a long way to go too. If we look at the CAPC palliative care grades, we also see large disparities in access to care across different regions and states. And this only gets to hospital-provided palliative care, which is kind of the end of the line and not really where we want to be grading ourselves on. We want to be grading ourselves on access in an outpatient and continuing fashion in early palliative care, not just in the hospital. But that's where this report card focuses on. But even within that, we're still not doing that well. We're doing much better than we did when this report card started, but there's still states with Ds, predominantly in the South, in this regard. But even when you dig a little further and you look at 50 to 100 bed hospitals versus those that are larger, the percent that have palliative care teams, and what that team may encompass is highly variable, and the quality provided might be highly variable. But smaller beds, which are likely to be more rural in nature, so another disparity, are less likely to have palliative care programs. And when we dig down even further and we look at nonprofit versus for-profit and public, our small public hospitals are lagging, our medium-sized public hospitals are lagging, and our for-profit hospitals are absolutely abysmal. So a lot of the South, where you saw worse grades, are primarily for-profit hospital systems. This is what you get. And so there are significant access issues, just to start off the bat. However, access is only one small part of the equation. And so when we come and look at quality outcomes, outcomes in underrepresented groups are by far worse. Underrepresented groups, particularly African Americans and Blacks, are less likely to die at home or in hospice and receive more aggressive care, though that is through the lens of the predominant view of what the outcome should be versus the goal concordant view, where it may be that because of the mistrust of the medical system for very good and well-published reasons, there is a proclivity or a cultural proclivity in some of these cultures towards more aggressive care. And so we do need to think about some of these outcomes, and as they're presented in disparities literature in our field, as about how they are worse outcomes compared to the view of the field, which is largely made up of white individuals within our country, and think about what this means from the perspective of the culture that we are portraying the disparity in. Similarly, LGBTQ individuals are more likely to receive discriminatory care in palliative care. There is less knowledge of palliative care in underrepresented groups. Underrepresented groups are less likely to receive palliative care, less likely to receive goal concordant care. And this, I would argue, regardless of culture, stands out because this means that the person is not being matched with the care that they actually want. And a place where palliative care in general is fairly good at helping to meet that goal. There are more transitions in care back and forth between the hospital, home, nursing home, et cetera. And clinicians overestimate survivals, which does play into this amongst African-American, Black, and Hispanic Latinx populations. And you'll notice the way that I use labeling here. Many Hispanic populations do not agree with the term Latinx. So while the predominant view is that we use that term right now, and when we actually go out into the real world, many people of Hispanic descent do not actually like or associate with the term Latino, Latina, Latinx. So just in thinking about our wording, African American and Black also can mean very different things. There are Black immigrants from Africa, from Caribbean nations, who do not consider themselves to be African American, who are more recent immigrants versus those who came through the slave trade and are descendants of that horrible practice. And so we do need to think about intergroup variation as well, and I'm going to come back to that concept. And then, few culturally tailored interventions exist. So Tessa Jones, Libby Luth, who are two individuals who work with my team. Libby has K99 at Cornell. Tessa is currently doing her PhD at NYU in the School of Social Work, as well as she and Lynn, who's a music therapist and a PhD trained researcher, have completed a systematic review recently focused on interventions, found only 16 interventional studies that specifically tailor towards underrepresented minorities. Think about the amount of literature that's out there. Think about that. 16 interventions were found, and only 2 RCTs, and both were of advanced care planning interventions. So a lot more dearth, and this work has not been published yet, so I'm not going to kind of dig more into details until it's been peer reviewed, but just to give you an idea of kind of some of the main findings. Now, because I don't want to show just bad things, I'm going to share some good examples as well. We have Marie Bakaitis and her work, which reaches through telephonic means, both nurse-led interventions that are telephonic in nature. They also have some navigator interventions that have primarily targeted African Americans in the Deep South. So this was Enable CHF, which did find differences in pain intensity and interference, but not quality of life. And while this is not about this, I would make an argument that quality of life is a bad outcome measure to use because it is too hard to change. And unless you get the intervention group just right, the quality of life is going to be too high to be able to show difference. And this is what we saw in this study. So if you're thinking about interventional research, my recommendation, do not use quality of life as your main outcome. Use individual components or symptoms or care plan, other outcomes, other that as your primary outcome. We have Stacy Fisher, who has completed her apoyo con cariño. Apology for butchering the Spanish. I have medical Spanish to know if someone has pain and dizziness, but my 4th grader speaks much better Spanish than I do. Stacy, Dr. Fisher's work, out in Colorado, just completed an NINR funded study. This is another one of her publications on this. Found no differences in pain management, but her main outcome was around advanced directive documentation and found significant differences. And so we need to think about what the right outcomes are for the right population and why we're looking at those outcomes. Another example, Rebecca Sudor, Dr. Sudor is based at UCSF, a geriatrician and palliative care physician. She's done a lot of work in advanced care planning and has tailored Prepare for Your Care for, while this says English and Spanish speaking older adults, it really has been tailored towards Central American and Mexican populations and done some of the tailoring work, found improvements in engagement in advanced care planning conversations and completion of advanced directives. And one more, this is not an interventional study, but Carrie Kanandrian, Dr. Kanandrian, based out in University of Colorado, has focused on LGBTQ older adults, and I think this title kind of says it all. She's dying, and I can't say we're married, relating to partners of LGBTQ individuals. So there are some examples of good work out there, so I don't want to present all doom and gloom, and I want to think about where we move forward, building on some of the work in our field and a lot of the work outside of our field. So we have some new things going on. This is Dr. Kim Johnson at Duke. She currently has a comparative effectiveness study looking at 2 different interventions for Blacks that are focused on different ACP interventions. This is in the field right now, just to give you an example. And Kim is one of the leaders of looking at health equity within palliative care and geriatrics in particular. And I encourage you to look at her broad swath of work. And so I'm going to talk a little bit about how we've incorporated equity within palliative care. And then I'm going to come back to some frameworks to think about in moving forward and some pearls. So I'm going to start with the Impala Study, which is another one of the PCORI funded studies that was funded in the same round as Kim Johnson's work. Karita Gridson is our PI on this particular study, and it's comparing 2 established palliative models, nurse-led telephonic case management, which, by the way, while it's an established model, there are no established protocols out there in how nurses should be doing this, and then facilitated specialty outpatient palliative care. And so our goals are to look at, is an outpatient palliative care visit given by a physician or nurse practitioner primarily equivalent to nurse-led telephonic care? And so that's really what we're looking at. We're looking at quality of life outcomes, healthcare use, loneliness, burden on caregivers. So it's semi-pragmatic, but we are collecting data directly from participants as well. Our recruitment goal is 1,350 patients and 675 caregivers. That July 2021 is old because of the pandemic. Forgive me, I forgot to update that. We're now going into 2022 now. And we're at 10 ED sites, so it's emergency department initiated. So these are taking vulnerable patients who have gone to the ER for their serious illness and are now either being put into outpatient palliative care or telephonic care that are being delivered by clinicians. So there's no true protocol. It's standard palliative care, standard telephonic palliative care, and it's based on what the clinician believes the needs are. We have done some work on a framework for the nurses in terms of their telephonic arm, and I'll talk about that in a second. But our goal is to really look at standard of care, not to look at pie in the sky care. One of our sites, while this says NYU Langone Health, two of our primary sites are NYU Brooklyn and Bellevue. Bellevue is one of the largest outpatient palliative care practices in the country, led by Dr. Susan Cohen. It is an amazing group. It is probably one of the leading practices in public safety net hospitals anywhere. And so for those of you not familiar with it, there's a lot of work that comes out of there. They do an amazing job with a highly marginalized population. Pat asked, did we engage through these sites through PCRC? We did not, because this was an ED-based intervention. And so we used an existing ED relationships that we had. Several of the PCORI studies have engaged, including Jennifer Temmel's study, have engaged through the PCRC to do that. We didn't, because we were looking at EDs as the primary site rather than palliative care leadership. And Karita, Dr. Goodson is well-known at developing ED networks. So that's why, but I also serve on the steering committee of the Palliative Care Research Cooperative. So I will take that moment, Pat, to put a plug in for using our services in trying to develop study sites, trying to think about caregiver interventions. We do have pilot grants, we have intensives, a whole host of different things. If you're not a member, I'll urge you to become one if you're doing research in this area. And so please go to palliativecareresearch.org and look at the huge wealth of resources there and cores and technical expertise. So thanks, Pat. Eligibility for this study, I'm gonna kind of breeze through, but essentially seriously ill older adults who are at least 50 years of age. The idea here is that they're getting either telephonic support or outpatient clinic support. They will have telephonic follow-up surveys done by blinded research coordinators. They do receive some incentives. This is a PCORI study, so there has been stakeholder engagement from before we initiated the program. Let me say that again. Before we initiated the program, before we put in the grant, we had stakeholder involvement in the development of the protocol, in the development of what the telephonic program should look like, how we could ensure equity and access from before we did all of these things. And so I'm going to say that again, before we did all of these things. Involving stakeholders later on is too late. You need to do it before you develop the intervention or as you're co-developing the intervention, or if it's not intervention-based, as you're considering how to implement within whatever communities you're implementing with. Within the outpatient PIC clinic, they have a baseline visit and then follow up as once a month or as appropriate for 6 months. There's a pre-visit call to introduce the palliative care team and a reminder. It's a multi-domain kind of standard assessment. On the telephonic arm, the nurse will speak to the patient over the phone, starting out weekly, but can extend to longer. It's really built around a few things: advanced care planning, symptom management, and engaging with their primary provider, whether that's oncologist or hematologist for cancer purposes, or primary care provider, heart failure specialist, et cetera. And so it's really engaging around those two things. There is training that these nurses have received in terms of respecting choices, serious illness care model, a symptom management guide. They do have to work through 3 problem intervention goals, which are essentially problem solving. They're for shorthand called PIGS, because that's what the acronym leads to. And one of those problems has to be ACP. And so those are really how it is structured. And here's the good and the bad and the ugly. Telephone-based care has more touches and no-shows are limited. So we're looking at like 50% no-show in the clinic, which is fairly standard for outpatient palliative care clinics. I'm not going to talk about the pandemic data because that just throws everything out of whack. But before we hit pandemic, and on top of that, the telephonic nurses are going to reach people who have difficulty getting to clinics for any number of social, emotional, physical reasons. And so that is of high benefit in terms of meeting people where they are. This is telephonic care. I know there's been a lot written about telehealth. I'm going to distinguish that because most telehealth billing requires a visual component to it. This is solely over the telephone. Once you get into telehealth, there are just, it enhances disparities because of the need for internet access. We have people who, for instance, are planning funerals for their loved ones during COVID, and so they're running over their digital allowance. Minutes isn't as big an issue anymore. Gigabytes are. And so we're seeing that people can't access these telehealth services because of that. This is purely telephonic. The telephonic nurses can connect and develop long-term standing relationships with patients and their families. The challenge with not being physically present and understanding what is going on from the provider standpoint are issues, because our nurses are based at NYU, but they're taking care of patients across 10 different health systems, just to give you an idea of the challenge there. And so sometimes there are issues with reaching people. Telephonic care doesn't change barriers such as housing insecurity, socioeconomic status and resources, serious mental illness, mistrust. And we have found issues with, particularly with working with people with serious mental illness, has been a challenge for our nurses. That may be less of a challenge if people get into the clinic to some extent. There are also issues of suicidality for people who have bipolar, manic depression, schizophrenia, and we are getting those patients because this is a pragmatic inclusion criteria, which is really mentally challenging and leading to some distress amongst our nurses. So as we think about this, we also need to think about the providers that are carrying out this work. And then the other piece is that nurses, much as many of us are experiencing now, but this we've been experiencing since the beginning, can feel a little adrift if they're not working centrally. So our nurses work from their homes, which means that when we weren't bringing them in and having physical touch and now kind of more video touch, they felt adrift to some extent. And so these are things from a workforce perspective you need to think of. If you want to look at the protocol of how we're doing this, it was just published in Nursing Outlook in January. And so some of the trial keys that we found, the non-traditional models can reach patients who otherwise would no-show or don't have access, rural, not living next to a quaternary care center, 6-month waiting list to get into outpatient palliative care, which is criminal, but we don't have enough resources in outpatient care. It meets the patients where they are and are patient-centered. And relationships can be developed over the telephone. During the pandemic, technically we can use FaceTime. Our system won't allow that, but it is allowed at the moment, technically by CMS. When that ends, so do those flexibility, and God help it ends soon, though now they're talking about November for herd immunity. They can be either highly structured or relatively unstructured, but they don't address the underlying lack of resources. And so that is something that we still need to think about how we do that. And so one other thing I'm gonna bring through in terms of our work is our Alleviato dementia care. Alleviato means relief in several different Latin languages or relatively similar translations. And our goal is improving quality of care, though we include issues around cultural tailoring and stigma within our programs for the specific reason that there are worse outcomes in Alzheimer's disease and related dementia specifically. So this is a symptom management, it's a palliative care intervention. We've developed it, initially I used the Orbit model. Now I'll talk about the NIA stage model in a moment around how you develop behavioral complex interventions. I will tell you that complex interventions are very difficult to implement, thus the complex piece of those things. They can have incredible outcomes, but the problem is they may be implemented variably in variable settings, and those settings that are richer may be able to implement them more because they have more resources, which means that you're actually increasing disparities and inequities rather than removing them, because we can't just use a rising tide lifts all boats sort of framework that doesn't work, because really what that does is it increases the tides of the has, and those that have not are not increased as much. So for instance, if we look at the pandemic, Bellevue is staffed by the same physicians as NYU is. Just to provide a disclaimer, my wife is a clinician at Bellevue. I practice at NYU. NYU has had an 11% mortality rate from COVID. Bellevue has had a 22% mortality rate from COVID, even though they are staffed by the same physicians. And so are receiving relatively the same treatments. So keep that in mind. You cannot just have improved quality through saying everyone gets the same thing. That doesn't work. And so kind of getting back to this program, we've developed it now over 12 years. It goes back to my experiences working in house calls, caring for people living with dementia and their caregivers. And it used to be called Dementia Symptom Management at Home program. We've now developed it under this Alleviato kind of framework of relief. And it's really about relief from symptoms and suffering. The program itself includes training, a toolbox of caregiver education materials that right now are in both English and Spanish at a 6th to 8th grade reading level, care plans, treatment algorithms, and mentoring. We've also now incorporated behavioral economic nudges into this for the clinicians to remind them about all of these tools. Just as a brief aside, training alone does nothing if you don't include other reinforcement mechanisms and changes to the care. Everyone reverts to the mean within about 3 months. So you cannot just train people and hope that it succeeds. And so this is what we've learned. We've gone through multiple iterations now. I'm not going to get into the details. You can find that elsewhere because this is about a different topic. But I did want to take through a couple of the things that we do train. So around stigma of dementia and helping clinicians, remember, we are teaching home health clinicians and hospice clinicians about dementia. While close to 50% of home health patients have cognitive impairment, and it is now a primary secondary diagnosis in 45% approximately of hospice patients, they are generally, neither of these clinician populations are trained in how to care for this population. So we take them through stigma and how to avert stigma. We take them through how to think through culture within dementia. And rather than go, and I'm gonna credit Tessa Jones, who's the social worker who I think is on this call, with helping us think through some of these elements. And it's one of the important things about having a well-rounded and both from a disciplinary and from diversity standpoint is that you get different lenses through which to think through things. Kamal's participated in this as well. She's been through these modules and she lived to tell the tale. But it comes through through the training modules. The other thing we talk about is rather than using a deficit model, we talk about unmet needs. And so why are the behavioral symptoms occurring? It's unmet physical needs, unmet intellectual needs, unmet emotional needs, unmet capabilities, unmet environmental needs, unmet social needs. This all comes from a model that is in Canada. This program is about bringing evidence-based care together. I'll point to you to the social factor for a moment. Boredom, loneliness, and isolation are particular concerns right now in the pandemic, but it takes clinicians through how we address these unmet needs. And so the two study designs are both ongoing. We have an R01 in home health, which is a hybrid stage 3, stage 4 randomized trial 3 home health agencies, 20 teams randomized within those agencies. The real focus I want to have here is on thinking thoughtfully about your study setting and site. So purposefully, as we went through choosing sites for this study, in addition to the intervention components, it's about who you choose to ensure you are addressing the needs of diverse populations. So we have one agency that is very large, urban and suburban, and does have some rural patients as well, nonprofit, highly diverse population. So it is hitting inner city Newark. They actually do take care of people in Camden, though we're not including the southern part of the state in this study. And they have presented, because they are large, they have more resources, but they're actually an amalgam of multiple agencies that have joined together. So there's a lot of care differences across those agencies, and some resources are care teams, and there are some care teams that have greater resources and some care teams that have fewer. Our second is medium size, it's in Utah. It does not have a highly diverse population in terms of racial, ethnic, though more than one might expect, because you have to remember Mormonism does go out across the globe, and then does bring back many people from across the globe into their communities. And so it's a little bit more diverse than you might think it is, but largely we chose this to hit a rural population. And then an agency in Southern Florida, which has a large, particularly Cuban immigrant population, Latinx, Hispanic population. We do longitudinal data collection, as well as collecting secondary data, and we're going to compare our gold standard data collection to what is collected by the hospice to see if there are real differences in how they perceive care and our standardized data versus how our gold standard data collection occurs. The patient population so far, 52% Caucasian non-Hispanic white, 30% African American and Black, 13.5% Hispanic and Latinx of our 156 dyads of caregivers and patients that have been recruited. The thing I'm going to share with you here is that you need to think about dyadic. When you're thinking about interventions that are dyadic, you need to think about dyadic analyses as well. So if you're working with caregivers and patients, Impact Collaboratory has a whole team working on this problem right now, because you can't just analyze them separately. So just as an additional thing to think about here. And then because this is longitudinal, you do have to think about changes over time, and that each intervention point is not independent. They're all interdependent, and you do need to use repeated measures. The study design in hospice is an R33. It used one of the R61, R33 mechanisms, which had a preliminary year. I'm not going to take you much through that other than how we stakeholder engaged to improve the intervention during that time. The study design is a 25-site step wedge trial. I don't recommend you use step wedge trials in the middle of a pandemic because they get blown up. And we now have a 5-site trial and a 20-site trial because of that. The 20-site trial is just restarting in February. We use stakeholder engagement processes related to readiness, data collection processes, further intervention modifications, and implementation processes. And we chose sites intentionally, again, to ensure geographic, profit status, and racial and ethnic variability. And so, when we engaged our stakeholders, we increased the flexibility in how we collect data because of the limited flexibility of hospice EHRs compared to, let's say, Epic, which many of you are used to. I know Columbia just came over to Epic. NYU's had a little bit more experience with it. We created a mobile health app that will allow for clinicians to access tools in the field because their EHRs are so difficult to use. And that will provide us with patient-reported data over time, patient and caregiver reported outcomes that we can match with the pragmatic outcomes data we're collecting. And so this will give us information from our diverse populations specifically that we can look at in terms of whether there are differences in the amount of utilization in diverse populations. There's another study that they haven't published yet, but is a similar pragmatic trial in nursing homes. And those low resource nursing homes did a worse job of implementing the intervention. Those low resource nursing homes also had much greater Black and African American population. So it's about the implementation and about how you implement and where you implement. We also created a home health aid program. So hospice includes aides as well. Our stakeholders asked us to create a program for them and to do it in English and Spanish. And so we've done that based on listening to our stakeholders. And then we've modified the social work and chaplain tools even further to demedicalize it further. Our outcome measures are looking at antipsychotic use, which are way overused, particularly in African American and Black populations, because they are seen, there are racist tendencies to see agitation in a different light in Black and African American populations. Much more likely to go straight to antipsychotics to essentially sedate those populations, which is a bad outcome. Those interventions have black box warnings, will kill people sooner, and will also make quality of life worse because they will get sedated in the day, be awake at night, and the caregivers are then up at night in addition to their other responsibilities during the day, and it creates a vicious cycle. We're looking at bereaved caregiver satisfaction, hospice disenrollment, which some work by Libby Elizabeth Luff, Dr. Luff, who's on this call at Cornell, has found Black and African Americans are more likely to be disenrolled in hospice than other populations. And then we are going to perform secondary analysis by race, ethnicity, and sex as required by NIH. I'm going to come back to that in a second because I'm going to argue that we have to do much more than that. And our NIH reviewers have to do much more in addressing some of the issues that occur in what we decide. We don't decide to fund, but we decide how to grade things within NIH grants, and we have to do much better as well in that aspect. And then we're looking at implementation and fidelity measures in order to see if there are differentials around how this is implemented in different populations as well. And so these are the 16,000 patients who we've received data from pre-enrollment. One of the benefits of pragmatic trials, yes, you heard that right. This is 1 year of data, 25 hospices, does not even include all of our hospices, 16,331 patients. So it allows us to do a lot of analyses that smaller stage 3 trials would not allow us to do. And so that's a benefit. You'll see we have very diverse population, less so in terms of rural, but I think that's more of a data glitch of how we define rural and need to come back to that. This was just DSMB data that we have put into our report as of this week. You'll notice that Medicaid is and private insurance and self-insurance are relatively low. That is because if patients are on Medicare, which pretty much all older 65 patients, unless they are in certain small populations, Medicare will be reverted to over Medicaid as the primary population. However, not all states allow hospice for Medicaid patients. So while it's not as big of an issue for Alzheimer's disease and related dementias, because it tends to be an older population, for younger populations, this becomes a huge access and equity issue. So one thing I'll remind people to think about, moving out of the inpatient and academic medical center reaches underrepresented, seriously ill individuals where they are. And so you'll notice all of my studies are in community-based settings. I say that because I firmly believe we have to move palliative care out of doing all of our research in these settings because we don't address this enough. I say this knowing that Columbia has a large population of individuals from Washington Heights and the Bronx that receive care and some of the seminal studies in inequities in ADRD care come from Columbia University, and some of the amazing researchers like Dr. Jennifer Manley are at Columbia. we need to get out of our academic medical centers, even if our AMCs are providing care to diverse populations and underrepresented populations in research. And then we need to do more than just implementing interventions and a rising tide lifts all boats. Implementation has to be culturally tailored or informed, and the interventions have to speak to the underrepresented populations. And so as we think about this, one lens through which to view this, and I use this a lot, mainly because my funders and the people I work with the most are in NIA. There are other models. So it is not the only version. There's the Orbit model, which was also developed through NIH collaborative grants. There are several others as well. You need to use a model to this behavioral intervention research. Anything that is not a pharmacy, you should be going through behavioral intervention development models so that you don't get too far down the road into stage 3, stage 4 efficacy trials before refining the model first. This is not a story about this. However, when you're using this model, when you're in stage 0 and stage 1 and moving into the further stages of these models, you need to include stakeholder input as to how the model worked. And stakeholder can be very broadly framed, but if you don't include those people, those individuals, your model will not be speaking to the community that you were trying to speak to, and it will fail. And the goal of our work is not to get $6 million grants. Our goal of our work is to improve the care for seriously ill individuals. The grant is a means to get there, but if you waste $6 million that could have, of taxpayer dollars, that could have gone to someone who had gone through the foresight of engaging stakeholders and creating something that was more likely to work, you're actually making the situation worse. And so a couple of things to think about. This is from Dr. Chao-Chin Chevron at NYU, Center for Study of Asian American Health and colleagues. Here's a population health equity framework to think through about individual, community, the institution and organization, the policy, system, and environment, and then how kind of some of the social determinants of health consider within this life course perspective. Health in policy work affects things. Social marketing, which is incredibly important, that we're reaching the right folks, and we do that through stakeholder engaged marketing of the intervention, how we present interventions. And that comes through community-based participatory research and bridging the practice community gap. Another way you can think about this is the equity-focused implementation research framework. This is fairly complex model. I'm just presenting the picture for now so that you are all aware and can go back and look at it. While I didn't use this model, we unintentionally went through just about all of the steps of it because we were involving some fairly decent equity thoughts within our work. And so I think the other piece, though, is I've never really spent a lot of time focusing my work on the equity messaging within it. I focused it on how we're improving quality. And I think it's important that we also focus on that from a messaging standpoint to show people that we are performing this work in the field. And so that my thought process has changed on that over the last year or so, that we really do need to bring out where we are going through these processes, bring it out and show it to the world as models that this can be done and needs to be done in serious illness care. One other thing I'm going to show you, I have borrowed this from Dr. Melody Goodman, who I'm speaking to later today, and I just heard her talk 2 weeks ago. And you can find a link to a full talk that she gave at NIH last year, which she's updated modestly since then. If you're going to do engaged research with communities, here are 8 engagement principles, and she has developed with colleagues a survey tool for how good your engagement is. And if you were going to conduct this research, if I was starting all over again, I would now use this tool. It's very new. They're doing some more work to simplify it, but I'm going to promote this work because I think it is amazing. And she's the Associate Dean for Research at the College of Global Public Health at NYU. And so the last thing I'll share is this is a study that comes, or a commentary that comes from 2008. And it is just as prescient now as it was 13 years ago, which is a little bit sad to me. This is from Dr. Keith Whitfield, who is now the provost at UNLV. He's a phenomenal geriatrics researcher. And here are two quotes that I'm snipping out of it. We argue that comparison studies, however necessary to establish inequities, are not sufficient to advance the science of diversity. You cannot just compare Black and white and do intra-group differences. You also cannot use white as the default group, because then that is gearing everything towards that group as the default, and everything else is a deficiency model, versus the cultural variant model, which describes differences, adaptations to external forces, for instance, racism, exemplifying resilience in the face of oppression. Differences are explained not in relationship to a majority or superior group, but as culturally rooted internal explanations. And this model is definition allows an appreciation for between group differences, and it challenges one to explore within group heterogeneity. So for instance, Cuban Americans versus Mexican Americans, just as an example, more recent Blacks versus African Americans. So it's not just about subgroup analysis, and it's not just about comparing one versus the other. It's about including a panoply of different elements and how we think about those elements. And so as we end up, I'm just going to put a plug in for pragmatic trials and for the pilot grants program for the Impact Collaboratory, which is pragmatic trials in Alzheimer's disease and related dementia, which includes palliative care interventions. We have one palliative care intervention, which is on the cusp of being funded, and we're just waiting for the final sign off. You'll notice that Kathleen Unroe and I are the leads of the pilot core. We are both palliative care researchers, so just a thought there. We fund pilot studies that we hope to move to full-scale embedded pragmatic clinical trials, LOI of non-pharm interventions. Letters of intent are due March 5th. I gave one webinar yesterday on the RFA. I give another one on the 22nd. There are clear equity criteria within the applications, and they are scored as such. They have to be integrated into the proposal. This is one way that we have chosen to address this within Impact Collaboratory, is to ensure our funding opportunities require you to think about these components. And we have a health equity team that can help our folks that move from LOI to full proposal to address those things. So take home message, think about the locations you're performing your intervention, think about how you're tailoring your intervention, how do you engage your stakeholders, how do you monitor for differentials, how do you assess those differential outcomes among different populations, and how do you develop a more diverse clinical and research workforce to match the populations we care for and develop awareness of our biases. And the last one, Cardi Smith, is just about to get an R1 to do some of that work at Mount Sinai. So yay. So here's some of our team at Leviato and the Hartford Institute for Geriatric Nursing that have helped to make some of this work move forward. So I know we've hit 101 because we have some technical difficulties, so my apologies for that. I will be happy to stick around and answer questions.
Thank you. I know before, this has been fabulous, and I'm sure there's questions, and thanks for, some people are hopping off. Before everybody goes, besides thanking Ab, I do want to mention that on March 25th, our next seminar is going to be Jean Kuttner, and there's a registration in the chat. So please register, and everybody that's on will also get a survey for our evaluation. But Marlene, I think you had a question, so please go ahead.
I do. Hi, Ab. This is Marlene McHugh from Montefiore in Columbia. Thank you for the great presentation. I haven't read the Outlook study regarding the case management nurses.
Mm-hmm.
Did you find anything about decreasing hospitalizations in either of the groups managing these patients?
So the study is still ongoing. So we have another probably year of data collection. What I think we're going to find in the study is that there is more palliative care being provided through the telephonic nursing arm. I don't know if that is going to translate into fewer hospitalizations.
Okay.
I also don't know how COVID is going to affect our numbers. And so we may have a cohort from pre-pandemic and a cohort post-pandemic, and this group in between, their numbers may be all wacky. And so we may not get it as definitive answer as we want. I think we're going to see at least equivalence. If not, my hope would be greater outcomes from telephonic care, just because it increases access. And there are more nurses than there are physicians in palliative care.
Yeah.
There's a greater workforce, and I love my physician colleagues. There is a lot of great work that they do, but we need more models because we're not going to meet the needs with the palliative workforce we have.
Right. And I really strongly believe in the RN model. We haven't utilized that in palliative care enough, but it does help a tremendous amount with some of the workload. And we need to do a better job at that, I think. Thank you.
Thank you.
Hi, I do, Pat. This is Jing Jing. This is wonderful presentation. I really enjoy it. So I'm very it was very interesting when you say the quality of life measure is not very good measure to, it's not, and because a couple months ago, I just heard another colleague commented the quality of life measure does not incorporate the current the status quality of life. For example, they use the mobile app in your life is become more frequent in today's age, but none of these incorporate that measure. So can you comment more why you think the quality of life measure does not fit for the specific palliative care study?
Yeah, so I'm going to say this, saying that my R01 has quality of life as the primary outcome measure, and I regret that choice, which is why I share my warning with you. Quality of life is a hard measure to change. Mm-hmm. It is, it tends to have floor and ceiling effects. It is highly dependent on your population. So if you don't choose your population, it's kind of the Papa Bear, Mama Bear, Baby Bear conundrum. If you don't choose it just right, for instance, in Dr. Bakitas' Marie's study, they had a fairly high quality of life overarching within that study. So their primary outcome was now null. And so my concern with choosing quality of life as the primary outcome, not an outcome, mind you, I have no problem with it as a secondary outcome, but as a primary outcome, because it's hard to change those quality of life outcomes, even specific ones. So she's using a heart failure one, I'm using an Alzheimer's disease and related dementia one. It doesn't change a lot. And it depends on where your population is. And so it's just very hard to change. And so since your primary outcome is how most people value your study and takes away from, if it's a null outcome, your other outcomes which could be present, I recommend it to be a secondary outcome and not a primary outcome, and to choose component outcomes as your primary outcome.
Okay, yeah, that is very useful suggestion for all of us study symptom management. Thank you so much.
Any other questions in the chat or Well, I want to thank you. One other thing I wanted to announce is if you haven't seen it, we do have a call for posters. Yes, thank you, Ashley. We have a call for posters for our May 6th workshop. So we're going to be having a seminar. Our speakers are Billy Rosa and I can't remember the other person, a global person that does palliative care. And then after that, Betty Farrell is going to be a moderator for a poster session. So if this is for nurses only, but if you're a nurse doing palliative care research, an early career nurse, please put in a poster. We do have some cash prizes. So share it widely to people. So thank you, Ab. This is really super, and I really appreciate your time. And thank you for all the participants.
It was my pleasure to be here with all of you. My apologies for the technical difficulties leading to run over. So I appreciate you all hanging out with me for a few extra minutes, and onward and upward we go.
To the next Zoom.
Take care, everyone.
Bye.